Ever have that feeling when you swallow and things just sort of pause? Like your food's hit an unexpected red light on the way down.
Yeah, that sensation of things getting stuck.
Exactly. Well, today on the deep dive, we're going to explore that feeling, specifically looking at a condition called achalasia.
Hmm.
Basically, it's a problem with how the esophagus, your food pipe, moves food along. There's a hiccup, particularly with that muscle valve at the bottom, the lower esophageal sphincter, which doesn't quite open up as it should.
Right. And our aim today is really to give you a clear, memorable overview of achalasia. Great for revision, or if you're just trying to understand it better.
Yeah, we'll cover the lot.
Love
What it
that.
is, the causes, how it works, who gets it, the symptoms, diagnosis, treatment, outlook, the whole picture.
And we'll throw in some memory aids, maybe an example question or two to help make it stick.
Perfect. So we're looking at the definition, causes, the pathophysiology, epidemiology, clinical features, investigations, management, prognosis, and complications. Let's dive right in. What exactly is achalasia?
Okay, so at its core, achalasia is what we call an esophageal motility disorder.
Meaning movement.
Exactly, a problem with movement. You get two main issues. First, a loss of peristalsis, that's the normal wave-like muscle squeeze that pushes food down when you swallow.
Okay.
And second, the lower esophageal sphincter, that muscular ring at the junction with the stomach, it fails to relax properly. It just stays tight when it should open.
So the tube loses its squeeze, and the exit door gets stuck. What's going on underneath all that?
The fundamental problem is degeneration, a loss of nerve cells in Auerbach's plexus. That's also called the myenteric plexus.
Right, the nerve network in the esophagus wall.
Precisely. This plexus controls the muscle movements. When you lose the ganglia, the nerve cell clusters, the communication breaks down.
And that leads to...
It leads to what we call a functional stricture. It's not like a star or a tumor narrowing the pipe physically. The muscle itself just isn't getting the signal to relax and open.
Ah, I see. So it acts like a blockage, but it's a muscle function issue. You could maybe think of it like a door at the end of your esophagus that won't fully open, and the hallway leading to it has lost its conveyor belt action.
That's a great analogy. It captures both the peristalsis failure and the sphincter problem.
So what causes this nerve degeneration? Is it just random, or are there specific triggers?
Well, the most common reason is actually idiopathic.
Meaning we don't know the cause.
Exactly. We don't know the specific trigger in many cases. However, there's often thought to be an autoimmune element involved.
The body attacking itself.
Yeah, the immune system might mistakenly target and damage that myenteric plexus. Then there are infective causes.
Like infections.
Yes, particularly Trypanosoma cruzi. This parasite causes Chagas disease, which you see mainly in South America. It can directly damage the nerve plexus in the esophagus wall.
Interesting. Anything else?
Less commonly, achalasia can be secondary to something else, like esophageal cancer pressing on or involving the nerves, but idiopathic is the main one.
Okay, so mostly unknown, potentially autoimmune, sometimes infection like Chagas, rarely cancer. Let's dig into the mechanism a bit more, the pathophysiology.
Sure. So, as we said, functionally, the distal esophagus and the lower esophageal sphincter just don't relax like they should when you swallow.
Because of the Auerbach's plexus degeneration.
Correct. And this leads to an imbalance in neurotransmitters, the chemical messengers for nerves. Normally, you have a balance between excitatory ones like acetylcholine and substance P, which make the muscle contract,
Right.
and inhibitory ones like nitricoxide and vasoactive intestinal peptide, VIP, which make it relax.
Okay.
In achalasia, you lose more of the inhibitory influence, so the balance tips towards contraction, keeping that sphincter tight.
Ah, so it's the chemical imbalance driven by the nerve damage.
Pretty much. There's also some talk about damage to another cell type, the interstitial cells of Cashal. They're like the pacemaker cells for the gut muscles, maybe playing a role too. But the main focus is usually the neurotransmitter imbalance from the nerve loss.
Fascinating stuff. Now, who tends to get achalasia? Is it common? Does it affect certain groups more?
It typically shows up in middle age, say between 25 and 60 years old usually.
Okay.
And it's not very common. The prevalence is roughly 1 in 100,000 people.
So quite rare.
Relatively rare, yes. And it affects men and women pretty much equally.
Okay. Middle-aged, rare, equal MF ratio.
Got it. So how does it actually present? What symptoms would make you think, maybe this is achalasia?
The absolute classic symptom is dysphagia, difficulty swallowing.
Right.
But it's a specific type. It's usually progressive, starts slowly, might be intermittent at first,
Yeah.
and crucially, it's often for both solids and liquids. right from relatively early on.
That's a key point, isn't it? Solids and liquids, unlike, say, a structural narrowing where solids get stuck first.
Exactly. That's a big clue. Another really common one is regurgitation.
Food coming back up.
Yes.
Yeah.
Undigested food, sometimes just saliva, often happens effortlessly, especially at night when lying down. About 80–90% of patients report this. Wow, that high. That must be awful, especially at night, leading to coughing, I imagine.
Absolutely. That nighttime regurgitation often leads to a nocturnal cough, and sometimes aspiration breathing the material into the lungs, which can cause recurrent chest infections.
Okay, what else?
Some people get food blemish impaction, where food literally gets lodged.
Ouch.
Chest pain is also common. It can be retrosternal, behind the breastbone, sometimes crampy, sometimes just a vague discomfort after meals. It's often described as atypical chest pain.
Not like classic heart pain, then?
Not typically, no. And then, because eating is difficult and uncomfortable, weight loss is pretty common. That's always a red flag symptom, too, needing to rule out malignancy.
Makes sense.
Interestingly, some patients report reflux or heartburn symptoms, which seems a bit odd with a tight sphincter, but it can happen. And difficulty belching is another one sometimes mentioned.
Quite a list. Dysphagia for solids and liquids, regurgitation, cough, chest pain, weight loss.
Exactly, and it's usually chronic, building up over time. On examination, you don't usually find specific signs unless there are complications.
Is there a good way to remember those main symptoms? A mnemonic, perhaps?
Yes, you can use DIARC here.
Okay, KRW. Okay, break that down.
D for dysphagia, R for regurgitation, C for chest pain, A for aspiration or cough, R for reflux, though less constant, E for maybe an emptying difficulty or feeling full quickly, and W for weight loss.
KRW, dysphagia, regurgitation, chest pain, aspiration, cough, reflux, emptying difficulty, weight loss.
That's helpful. Okay, so someone comes in with these symptoms. How do we confirm it's achalasia? What investigations are key?
Imaging is really important. You might start with a chest x-ray.
What would you see?
It's not specific, but you might see clues. Things like a widened mediastinum, maybe a dilated esophagus visible sometimes as a double shadow on the right heart border. You might lose the normal gastric air bubble because air can't get down easily.
Right.
And sometimes you can even see an air fluid level in the dilated esophagus up in the chest. So, hints, but not diagnostic. What next?
A barium swallow is often a key test, sometimes done before endoscopy, partly for safety if you suspect cancer.
And what does that show in achalasia?
It shows the classic bird's beak sign.
Ah, yes, the bird's beak.
Exactly. You see the barium filling up a dilated, often tortuous esophagus, which then tapers down sharply at the bottom at the non-relaxing sphincter, looking like a bird's beak. Only a thin trickle of barium gets through intermittently.
And that's different from cancer.
Yes, typically cancer causes more of an irregular, shouldered narrowing, sometimes called an apple core or rat's tail appearance. The bird's beak is smoother, more tapered.
Got it. That image is really distinctive. What about looking inside with a camera, endoscopy?
Endoscopy is crucial, but mainly to rule out other causes, especially esophageal cancer, which can mimic the symptoms. You might see a dilated esophagus, maybe some retained food or liquid, but you might not see much wrong with the sphincter itself, especially early on. It only picks up maybe a third of cases directly, but it's vital for excluding malignancy and taking biopsies if needed.
So barium swallow gives the characteristic look. Endoscopy rules out nasties. What's the definitive test?
The gold standard is esophageal manometry.
Measuring pressures.
Exactly. It measures the pressures along the esophagus and at the sphincter during swallowing. It's the most sensitive test, detecting about 90% of cases.
And what does it show in achalasia?
3 key things. 1, elevated resting pressure in the lower esophageal sphincter, usually over 45 millimillimeters G. 2, failure of that sphincter to relax properly when the person swallows. And 3, a peristalsis, loss of the normal progressive muscle contractions in the body of the esophagus.
So it directly measures the functional problems.
Precisely. If manometry is normal but you still highly suspect achalasia, you might think about pseudoachalasia, something else mimicking it.
Okay, manometry is the key then. Any other tests? Blood tests, maybe?
Yes, serology blood tests for antibodies against Trypanosoma cruzi. If Chagas disease is suspected based on where the person is from or traveled, you might even see the parasite on a blood film, though that's less common.
Right. Makes sense for specific situations. Let's quickly do an example question. Say, a 45-year-old presents with progressive difficulty swallowing both solids and liquids. Which investigation is considered the gold standard for diagnosing the likely underlying condition?
That would definitely be esophageal manometry.
Perfect. Okay, so we've diagnosed it. How do we manage achalasia? What are the treatment options?
Treatments fall into a few categories: medical, endoscopic like dilation, and surgical.
Let's start with medical. Any pills that help?
There are some. Nitrates or calcium channel blockers, like nifedipine. They work by trying to relax the smooth muscle of the lower esophageal sphincter, reducing the pressure.
Do they work well?
Honestly, their effectiveness is pretty limited. Maybe only about 10% get significant long-term relief. And they can have side effects: low blood pressure, headache, flushing. So not usually a first choice or long-term solution for most.
Okay, limited use for meds. What about more direct interventions? You mentioned dilation.
Yes, pneumatic balloon dilation. This is often considered a first-line approach, especially in some centers or for certain patients.
How does that work?
An endoscope is used to guide a balloon across the tight lower esophageal sphincter, and then the balloon is inflated forcefully. The aim is to stretch and rupture the muscle fibers.
Sounds quite forceful. Any risks?
Yes, the main risk is esophageal perforation making a hole. It happens in up to maybe 10% of cases, which is significant. If it happens, it needs emergency surgery.
Wow. Okay, so benefits versus risks.
Exactly. It can provide good short-term relief, and sometimes repeat dilations work better. It's often used as maybe a bridge to surgery or for older or frailer patients who aren't good surgical candidates.
Right, so what's the main surgical option?
That's a surgical myotomy, usually called a Heller cardiomyotomy or a modified Heller procedure.
Myotomy meaning cutting the muscle.
Correct. The surgeon carefully cuts the muscle fibers of the lower esophageal sphincter, and sometimes a little way up the esophagus and down onto the stomach, to permanently weaken it and allow food to pass through more easily.
How's that done? Open surgery.
It used to be open, either through the abdomen or chest, but now it's almost always done laparoscopically, using keyhole surgery, sometimes even robotically, much less invasive.
And is it effective?
Very effective. Success rates are high, around 90–95% in providing long-term symptom relief with generally low complication rates. It's often preferred for younger, fitter patients.
Any downsides to the surgery?
The main potential issue afterwards is reflux, because you've weakened the anti-reflux barrier.
Oh, makes sense.
So surgeons often combine the myotomy with an anti-reflux procedure, like a partial fundoplication wrapping part of the stomach around the lower esophagus, like an anterior door procedure. That helps prevent reflux.
Okay, so Heller myotomy, often with fundoplication, is a major option. Are there other less invasive things?
Yes. There's botulinum toxin injection, Botox.
Botox, like for wrinkles?
The very same. It works by blocking the release of acetylcholine, that neurotransmitter that causes muscle contraction. So injecting it directly into the lower esophageal sphincter via an endoscope helps relax the muscle.
Does that work well?
It can be quite effective initially, maybe 85% see improvement, but the big drawback is that the effect wears off.
How long does it last?
Usually only 6 to 12 months, sometimes less. So about 70% of people need repeat injections.
So not a permanent fix. Who is it best for?
Mostly used for patients who are poor candidates for dilation or surgery, perhaps elderly or with many other health problems, where the risks of the more invasive procedures are too high.
Okay, that makes sense. So summarizing the treatments,
Yeah.
maybe another mnemonic.
You could think MBSB again, but maybe slightly different emphasis. Medical, limited use. Balloon dilation, first line for some, but risks. Surgery, Heller myotomy, often best long-term. And Botox, temporary for specific patients.
MBSB, medical, balloon, surgery, Botox.
Got it.
Now, what's the long-term outlook? Can achalasia be cured? What's the prognosis?
Unfortunately, there's no actual cure for achalasia currently, as we can't reverse the nerve damage.
Right.
But the prognosis is generally good if it's diagnosed and treated properly. Most people get significant symptom relief with treatment.
And if it's not treated?
Without treatment, the esophagus can continue to dilate, sometimes massively, which can cause problems by pressing on things in the chest, and symptoms usually worsen.
Okay. And what about complications, either from the condition itself or the treatments?
Several important ones. From the disease itself, aspiration pneumonia is a big risk due to the regurgitation.
Right. Breathing in food or saliva.
Yes, leading to recurrent chest infections. Malnutrition and weight loss can happen. Some people get into the habit of self-inducing vomiting to relieve the discomfort.
That sounds tough.
It is. And a really crucial long-term complication is the increased risk of esophageal cancer.
How much higher?
Significantly higher, maybe up to 15 times the risk compared to the general population, particularly squamous cell carcinoma. The risk seems higher in men and those who've had achalasia for a long time.
Wow, 15 times. That's a serious long-term concern.
Absolutely. And of course, living with chronic symptoms can lead to depression or low mood. Then there are treatment complications we touched on, perforation from dilation.
Which might be higher risk after Botox.
Potentially, yes, as Botox can make the tissue a bit more fragile or fibrotic. Reflux after surgery is possible, though hopefully minimized by fundoplication. And symptoms can recur after any treatment due to scarring or the disease progressing.
Okay, lots to be aware of there. Finally, when someone presents with these symptoms, what else needs to be on the list of possibilities? The differential diagnosis.
Good question. You definitely need to think about Chagas disease, especially if the person's from an endemic area.
Because it causes a similar esophageal problem.
Exactly. Esophageal cancer is top of the list to rule out because of the similar symptoms like progressive dysphagia and weight loss.
Right.
Benign esophageal strictures, perhaps from previous reflux or injury. Sometimes gastric cancer involving the lower end of the esophagus. Maybe severe gastroesophageal reflux disease, GORD, although the pattern is usually different. And very rarely in children, Rosicki syndrome.
So a few key mimics to exclude.
Yes, a proper workup is essential to nail the diagnosis.
Well, this has been incredibly thorough. We've really unpacked achalasia from start to finish.
We have. I think the main takeaway is that while it's not curable, achalasia is definitely a manageable condition. Understanding the why behind it, how to diagnose it accurately, and the pros and cons of the different treatments is key.
Absolutely. And maybe a final thought for everyone listening. Considering that significantly increased risk of esophageal cancer long-term, what kind of surveillance strategies might be best for people living with achalasia? Definitely food for thought.
It is indeed. And if you are looking for more revision resources on achalasia or other topics, don't forget to check out paththenmsra.com.
And freemsra.com for free questions and resources too.
That's right.
Thank you so much for joining us for this deep dive into achalasia. We'll catch you on the next one.